talk to only 10 minutes. So, since the start of the first successful hemodialysis during the World War II, hemodialysis has saved lives of a lot of end-stage renal disease patients. However, current hemodialysis appears not to be ideal. We have 5-year survival, which is nearly similar to cancers. And we have what's called hemodialysis paradoxes. So, in contrast to general population, men dies more than women on hemodialysis, and obesity is a protective factor on hemodialysis. So, it appears that current hemodialysis is not an ideal solution. So, what about the future of hemodialysis? So, starting with new dialysis regimens, we have trials of extending hemodialysis. So, instead of the conventional 4 hours, 3 times per week hemodialysis, trials are to extend hemodialysis or making it short and very frequent. So, doing it nearly daily instead of the standard hemodialysis. So, 2 hours, 5 to 7 times per week is short daily hemodialysis, and this might increase efficacy and stability. And this can be done at hospital or at home with better survival despite the same KT over V. Short daily hemodialysis needs very good vascular access to achieve very good dialysis within a very short time. A second modality is what's called nocturnal hemodialysis. That's to say, doing dialysis during the night, extended, very slow dialysis, sparing time for the patient to do more activities during daytime. And again, it could be done at hospital for 8 hours, 3 times per week, or instead at home, and in such case, dialysis will be done almost daily. In contrast to short daily hemodialysis, nocturnal slow hemodialysis doesn't need a very good vascular access. Rather, only 200 ml per minute is sufficient to perform nocturnal slow hemodialysis because it's being performed over about 8 hours per day. And instead of using sharp usual needles, we might use blunt needles for what's called buttonhole technique to be easier for the patient or the caregiver at home to cannulate the patient without much pain. And single needle dialysis might be suitable here for more safety and giving slow dialysis. However, frequent hemodialysis in general, whether nocturnal or short daily hemodialysis, carries a risk of more vascular access problems. However, it appears that it will be a place for these frequent and long-term duration hemodialysis in the near future, to the extent that K2K, revised last month, has suggested to offer new end-stage renal disease patients the option of doing nocturnal frequent hemodialysis or short daily hemodialysis as an option for them beside the conventional hemodialysis, telling them that there will be some risk of vascular access problems, but at least they are here in the recent guidelines, and I think they will have a place in the next future. So, the second issue about future of hemodialysis is new dialysis technologies. So, just we were talking about doing dialysis frequently at home, at hospital during the night. So, we need to telemonitor patients. So, instead of attendance for every dialysis session and a nurse is attending the whole dialysis session, there is a room for what's called telemonitoring, transferring data of patients from a remote hospital or home to a center that guides and monitors their data and interferes accordingly. And because we are doing frequent unmonitored dialysis, so the issue of intradialytic hypotension might be important. And here a new technology called biofeedback system. So instead of using the usual machine, there are new coming machines which are intelligently sense the patient. So if there is some manifestations that will tell the machine that the patient will develop hypotension after half an hour or 15 minutes. So the machine intelligently interferes to decrease the possibility of this intradialytic hypotension. And there are many ways of this biofeedback mechanism to monitor the patient, either by monitoring blood volume of the patient, using thermal balance, measuring the plasma conductivity of the patient, or making a very intelligent algorithm. That's why the patient here will retrieve the previous patient blood pressure data and measure the new current blood pressure at the start of the current session, and then intelligently calculates the rate of ultrafiltration according to the current situation of the patient. So this is biofeedback mechanism. So the patient will be dialyzed by more intelligent machine. And we have also what's called renal tubular assist device. So instead of doing regular dialysis and losing too much amount of solids in the dialysate, so the technology tries to imitate the nature. So we have in the nature we have glomerular filtration and then tubular reabsorption. So this technology depends on the same idea. So after doing ultrafiltrate, regular ultrafiltrate, the ultrafiltrate will not be will not go to the sewage, but instead will enter another filter here, and this filter contains proximal tubular cells trying to retrieve and reabsorb the useful solids again to the blood before discarding the dialysate. So, renal tubular assist device. Up till now, it is only tried in acute kidney injury, but in the next future, it might be another option for end-stage renal disease patients. Still, there are some problems with source of these cells, storage, and costs. Wearable artificial kidney, that's to wear an artificial kidney during dialysis. So this is Dr. Gura helping one of his patients to wear this artificial kidney. It is about 5 pound weight, weared like that, using vascular access. And And previous trials had about 8 patients, dialyzing them for 4 to 8 hours per day, and it was well tolerated. And recently, Dr. Gura announced for the inclusion of 21 patients to be dialyzed all over the day with wearable artificial kidney WAC. And this wearable artificial kidney provides urea clearance of about 20 milliliter per minute. And if we combine renal tubular assist device with this wearable artificial kidney, then we will have what's called wearable bioartificial kidney. So it is a wearable kidney with some tubular cells inside. Again, vascular access is the main issue here. And the last part of my talk is about other alternatives to hemodialysis. With the use of nanotechnology, instead of inserting normal tubular cells, they are trying to construct, like bioengineering, artificial cells, simulating the glomerular and the tubular membranes. And the company expects that this will work for 24 hours, and it will be in the size of like a diver watch, and it is coming in the next 3 or 4 years. And again, if we combine renal tubular assist device with this artificial nephron system, this one, we might have what's called implantable bioartificial kidney. It is not wearable, it is implantable. Instead of transplanting the patient with a kidney, there might be room to transplant the patient with this bioartificial kidney instead of the kidney from a donor, like a normal kidney. And they expect that animal trials will be like after 1 year, but it will take like a few years if successful. So lastly, stem cell. Dr. Yamanaka, an orthopedician who failed to practice medicine, has shifted his work to stem cell field, and he has got a Nobel Prize 3 years ago because he was able to convert normal cells from skin, for example, to pluripotent cells. So instead of taking stem cells from an embryo, which is unethical, you might have problems with the source of stem cell, just the patient skin cell can be transformed to pluripotent cells, and then hopefully injecting this pluripotent cells inside in the deceased kidney might result in a new kidney from the same patients. So now we are here. Hopefully, after 10 years, you might come and find no more hemodialysis courses, not because Professor Hussein is not there, he is there, but because no more dialysis. Thank you very much.